Beep. Take two. Welcome to the next installment of the Many Minds podcast. Many Minds for better outcomes. We are here to collaborate with each other and find out what makes each specialty special. How can we help you and assist you in what you're doing? And let's come together and provide better community care. I am Alex Davis, physician assistant, along here with Tyler Murray, nurse practitioner.
So, general disclaimer, this podcast represents the opinions of myself and Alex and any of our guests that are on the show. The content from this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. We're just here to talk and have a good time. And with that, we're going to jump into this week's episode. We have the privilege to have Sarah on the show. First and foremost, Sarah, I just want you to tell everybody kind of about yourself, your background, and where you're at currently within your specialty.
Okay. I first started as an orderly. I believe we worked together as an orderly, right?
We
at the
did.
Hospital, in the OR. So that's where we started. And I first realized I wanted to be in the OR. And then after that, I went to BYU, got my exercise science degree, which I believe you said you did as well.
I did, yep.
And then I wanted to do the med school route and was heading in that direction, was pre-med, very passionate about it, and ended up getting married. It kind of ruined all my plans.
It derailed you.
Yes, it did. And I just realized I wanted kids a lot sooner than I was planning on originally. And so I needed something that would be like a quicker route and would also be very flexible at the end after I graduated. And so I decided med school might not be the thing for me personally. And so then I looked into nursing school and I went and got my bachelor's degree in nursing at the University of Utah. And
hold up. You're a
yes.
PA.
Yes.
Sarah.
This is what I'm excited to get into.
Why nursing?
Why did you go to the dark side?
I know. It seems
kidding.
to be a very common thing on both sides. Like the nursing side kind of wants to jab at the PA side, and then the PA side wants to jab at the nursing side.
And can I just say something real quick? So we worked with an individual that went and fast-tracked the nursing program, but wanted to go into PA school, and then realized, and the reason he said that he wanted to go into PA school was clearly because of the title. He didn't want to be called a nurse practitioner. Do you know who I'm thinking of? We worked together with him.
No.
I will not call his name out, but I will tell you after this.
Yes, please do. I'm now curious.
But that was the main reason. And we were orderlies at the time, so in the beginning of our careers, and I was like, why would you do that? Well, fast forward, he didn't get into PA school at the university he wanted to, so then he went to NP school. But I thought it was so fascinating that we do take different routes and have kind of different ideas. So I just want to know from your perspective, why PA over nurse practitioner?
It was totally a personal decision. So I already had a bachelor's degree from BYU in exercise science. So when I was in nursing, getting my bachelor's there, I could apply to PA school while I was in nursing school. And so I thought, why not? Like, I know I want to go further. I know I want to go to grad school, so let's speed up the process. Whereas most people that do nursing, usually they want 2 years of critical care before you apply to nurse practitioner school. And of course, I'm wanting babies, and I want to get finished with school so I can have the babies. So I was like, I got to speed up this process as much as I can. I applied to PA school while I was in nursing, and I ended up starting my PA program a month before I graduated from my bachelor's in nursing. So they overlapped a little bit. Oh my goodness, that would have been
hard to do both things because they're both pretty rigorous.
Yeah, and one was in a different state, so it was a little crazy.
Well.
On top of managing family, being a mom.
Well, I wasn't yet.
You weren't
yet. That's the only reason I felt like this was possible, because once I had kids, I'm like, I love being a mom. So
did you ever work clinically as a nurse then?
I pulled like a few nursing shifts because my PA program, which is Touro University in Henderson, Nevada, they have Jewish holidays.
Right.
So we had a lot of holidays, and my husband stayed living here in Utah while I was down there. So I'd come home all the Jewish holidays and pull shifts. So
in what setting for the nursing?
I did mostly PACU. It's the post anesthesia care unit. So
and you were very familiar with that setting, obviously.
And I had already been an orderly there. I knew all the people. So yeah, it wasn't like super frequent, but I wanted to keep my employment status current.
Do you still have those up to date? Have you kept your licensing up to date in nursing?
No, not for nursing. I didn't for that. But I still am employed by, like, one thing that was super helpful with that is I'm an employee for Intermountain, which they do internal hires, at least at the time. I don't know if they still do it this way, but internal hire was easier than it is to get one externally. So when I graduated from PA school, it was easier for me to get a job with Intermountain because I was already an employee.
That makes sense.
So I'm glad I kept that up and pulled a few shifts here and there just to keep that and my pension. But of course the money side. But
of course.
Yeah, so it did help me land a job I absolutely loved out of school.
How's that relationship been? Tyler's kind of alluding to some of the jabs back and forth between the two professions, which ultimately in the end,
nurse practitioners are better. I mean, no, I'm just kidding. I'm totally kidding.
It's a problem.
It is, yeah. But ultimately, in the end, serve a very similar role.
Right.
I can't say that I would even know the difference if I didn't look into somebody's credentials because essentially perform the same job. But what's been the critiques back and forth? What's your experiencing been having?
I noticed there were actually quite a few comments in PA school about nurses and NPs. In school mostly. And I would always be the one to be like, actually, I'm a nurse. Be careful what you're saying because it's not true. And just that we do in most areas like the same thing. And most areas we make the same amount of money and we have the same responsibilities. And there are a few situations which I actually ran into. We have a friend, Jared Price, who does like hormonal medicine, and he was asking me to come work with him and if I had to be signed off by a doctor, because that's one thing is they do practice independently. Right. So if you are looking into something along those lines, they do have the ability to practice independently. But as far as like what I've experienced in my career so far, I've never had it be an issue because all the things that I do and specialize in, there's always a doctor there. Yeah. So it's never been an issue for me.
Yeah.
And on the nurse practitioner side of things, it varies state to state. So there are certain states that allow nurse practitioners to be autonomous and then others that are very restrictive. So I think that's an ongoing conversation. And I know in the PA space, I think you guys are advocating for more autonomy, which is great. I think that's what we want. But yeah, so let's fast forward a little bit. So your first advanced practitioner role, was it the role you're in now?
No, so I started in thoracic surgery right out of school at IMC, the big medical center in Murray, Utah, and absolutely loved it. I loved the patients we were taking care of. I loved what we were doing. I obviously wanted to do surgery, so it was a dream come true for me, and did that for a few years.
What did that look like? Like, what were you doing? Obviously you were in the OR, but talk to us a little bit, detail kind of what you did day to day.
So my role is like a PA. We had more than one. So I think when we started, we had one other PA and one or two nurse practitioners. And we were part of the cardiothoracic group, but the cardiac surgeons were actually separate from us. So we had our specific thoracic surgery and cardiac surgery, even though we were in the same group, and eventually split while I was still there. But in that role with thoracic, we would round on patients, we would do surgery, we would also do clinic time too, mostly like post-op stuff. I think now they're doing more of the new patient visits and things like that. That kind of started as I was leaving, but yeah, we got.
Are you doing a lot of like closing of incisions, like?
Yes, everything in the OR. We would start with the surgeon, end with the surgeon. We were there the whole time, and some of those surgeries can, if you're going in for esophageal cancer and doing an esophagectomy. Sometimes they were esophagectomy. Yeah, they could be like 6-hour surgeries. So. Or longer. So sometimes they were long. Yeah, I'm sure you guys are used to that.
I think people underestimate how taxing it is just to stand still for 6 hours.
That long.
It doesn't seem like that would be a big deal, but it's taxing.
Yeah, it can. And I feel like even the care after those surgeries when you're in the ICU, it can be taxing too, because they need so much management right afterwards, and it's kind of a critical time to keep your eyes on them. So
Yeah.
I loved it. It was awesome.
How long did you do it for?
I think 3 years.
Oh, wow.
I'm pretty sure it was around 3 years. It was more, I did it even through having my first baby. I went back full time, and I just got to a point where managing a baby who was up all night and call, because we also did call. We worked with fellows too, so they would help us in our rotation of who was where. But they took a lot, probably the bulk of the call, but we still would do some weekends and some weekdays where we'd be working like a 12-hour and then on call all night and then work another 12-hour the next day. And I think before having a child that was awake a lot at night, it was manageable and I really did enjoy it. But then it was just really hard to be answering the phone and answering my baby monitor. So
stages of life.
Yeah, exactly.
Change.
And I just realized like I want to be able to be in a career where I feel successful in both areas.
Yeah. Right.
And I needed a change.
Yeah.
And so I moved on to doing hospitalist work at the same hospital. And I just love the hospitalists at IMED. They're amazing. I still work with them PRN. But they just have such a good group up there. And I think what they do really embodies like what you guys are saying with this podcast of many minds, because they are the mind. They're the ones that are like reaching out to all of the different resources to manage people's care and provide quality care.
Yeah.
And if you have someone that knows who to talk to and who to reach out to or when to get palliative care involved.
About anything, right?
Yeah, like
Absolutely.
it just makes it such a better experience for patients. So I've learned so much and been so grateful for that opportunity as well.
Social currency, I say it all the time, social currency is sometimes far more valuable than actual money can get you. Is who do you know, how well do you know them, and
your relationship,
how's your relationship with them. What did you see, what was your experience in that scenario with having to collaborate so much, and what are the stumbling blocks, or how did tell us a little bit more about that?
I mean, I feel like they do a really good job up there. There are so many different avenues that they have nurses that usually work directly with you, as well as the physicians that are there. And you're all in like a big office. And if you have any questions, you have so many people to collaborate with to get answers. So I never felt like it was an issue. Stumbling blocks, though, as someone who wanted to be more part-time and be cutting back on my hours, I felt like to really give it my like 100%, it was more difficult because I mean, even just filling out like death notes, that was a whole new, doing death certificates. I'm like, how do you do that? These are all new to me.
Do I want my name on that? Are you sure?
What do I put for the, so just trying to figure out where everything was and where it was located. If you're not on top of it constantly and doing it all the time, it takes you a lot longer. And I found myself, just probably taking more time than I probably should have, whereas other people could take more patience and get the same thing done. And so I actually transitioned. They started this program, which is amazing, called Hospital at Home, and you probably haven't even heard of it.
No, I have not.
Because it's so new, but they started it during COVID, and so many good things came out of COVID, I think. This is one of them. So we have a Dr. Nathan Starr up there who started this program where patients who need hospital care can actually go home and receive hospital care as long as it's not too critical. So this helped us alleviate a lot of the like beds being used up by COVID patients who could possibly go home and still get IV medication, IV therapies. We can even do chest x-rays, but they don't have to be taking up a hospital bed.
Right.
So the more critical patients who actually need to be in the hospital can be there and get the care they need, but then we can manage patients like cellulitises and things that are kind of like long-term IV antibiotics, but they don't have to be in the hospital for that. So they still have the nurses checking on them. They log their vitals every 2 hours. We still have a provider visit through telehealth once a day. So if I can actually like lay eyes on the cellulitis, for instance, or like with COVID, like I can assess their cough and see how they're breathing.
Yeah.
And actually see them and lay eyes on them once a day. So it's actually this amazing program they have.
Sounds like a good direction to go. I remember my quick rotation through schooling of doing inpatient care with the hospitalist service. It seemed like there were always a couple of people on the hospitalist service that you would round on every day and you need to be charting on and checking on, but it was just copy and paste every day. This person is taking up a room, taking up a bed. Granted, there wasn't as much demand and need back then, but it seemed like there were a lot of instances where that would be probably ideal.
Yeah, and they're there long term, and you're basically managing like IV medications, or we've even started taking a lot more heart failure patients recently where you're just kind of tweaking their medications to get them to a stable like euvolemic state. But it can take a while. Yeah. And this way they can be at home with their families and sleeping in their own beds and
probably goes a long way too,
yeah.
I can imagine.
I think it's an awesome program, and they're continuing to grow it. So I still do that occasionally, PRN, but I then got offered a job I couldn't pass up. Yeah. So that's what I'm doing now.
That's real. And this is what I'm interested to get into. I obviously know everything about medicine, but imagine Tyler was a 5-year-old and you had to explain to him very basically, what is it you do now?
I am a unicorn.
Yes.
We're a 5-year-old.
5-year-olds love unicorns.
I know. Rainbows and sparkles.
That was perfect. Yeah.
No, that's what most people, when I take students, they always say that. Like, you have a unicorn job. And I'm like, yeah, this isn't probably reality for most people.
It is. It's very unique. We were talking about it earlier.
And I'm so grateful. I got offered a job by Valley Women's Health, and I absolutely love all of their doctors. And I knew them prior because I've been a patient there too for a long time. And so they offered me a job to be their surgical assist. And this is for, Valley is quite large across Utah, but this is specifically for their American Fork group. Okay. And so I surgical assist for the AF group, and we work at Intermountain Hospital at American Fork and here at Mountain Point Hospital. Doing surgery.
Tell us the types of surgeries you're...
You got to rein it in for me a little bit.
Okay.
My mind's wandering.
Well, I mean, still thinking 5-year-old, and I'm like, do I really want to talk about hysterectomies?
Okay, wait, yeah,
let's... Okay, now let's...
Are we adults now?
He's a 15-year-old now.
Oh, well, I don't know about that either.
It's probably not much better.
Why are we focused on my age right now?
Let's talk about birth control. Let's start there.
No.
But
when we had the conversation, when you told us what you were doing, we just looked at each other and had this little bit of moment of just like,
what does that entail?
What does that look like? And then I got in trouble because they told me you have to be careful with the words you use because they could be twisted on you. So I'm going to be very careful with what I say going forward. But please do just tell us kind of what it looks like what
surgical cyst only and only gynecologic surgery.
Yeah.
So what kind of things are you guys doing?
We randomly did an appendectomy the other week, but I wouldn't claim that on my surgical list.
Right.
So I show up to surgery. I'm supposed to have the orders in for pre-op, and I basically show up when the patient's in the room, and I do surgery. And then...
Is it a lot of hysterectomies?
Yes, so we do a lot of hysterectomies. I probably do I did 3 yesterday, probably 3 to 6 a week on average. And then we do a lot of diagnostic labs looking for endometriosis or other things going on, which is how we found a lot of infected, inflamed appendixes lately. So I was joking, but not joking, because we really have found quite a few lately. We do a lot of salpingectomies, taking out the tubes, mostly for birth control. But if someone's getting an ablation where they're having bleeding issues, but they might not qualify for a hysterectomy, we can do an ablation to help with bleeding. But you don't want to risk also getting pregnant. So a lot of times we'll do the salpingectomy at the same time. So it's just a form of birth control. Where at Holy Cross Hospital, they don't allow us to do that here. So we do most of ours at American Fork Hospital or a surgical clinic. But...
Interesting.
How many surgeries a week would you say you're assisting on? Or is that not the right way to ask that?
Well, I mean, it's so variable. That's why my job's also interesting, because I am scheduled Tuesday, Wednesday, Thursday to do surgeries, but most weeks it's very different than just a set schedule. I don't have a set schedule at all. It's when we have surgeries and when we don't. And a lot of that is not just scheduling. Insurances come into play, and what's been approved and what hasn't. And so I think that's another interesting side of it is I really don't. My friends will be like, can you go to lunch tomorrow? I'm like, I have no idea. And surgeries can go late. You never know till you're inside the body what you're getting yourself into. So something can take a lot longer, or it could go really quick. So
What is your kind of work week like then in general? What's an average week for you as far as hours and where you're at? And
Yeah, right now our consistent plan would be Tuesday, Wednesday, Thursday for 5 hours. Surgery starts at 7:30, so I'm always there by 7:30, ready to go. And then I would say most days I'm done by 12:30, but like yesterday, we had 4 longer cases and another one that canceled, so we were really scheduled till like 5 o'clock, but I think I went home at like 4:30 last night. So it kind of varies.
Is this considered part-time work for you, or is it a full-time, part-time gig?
No.
Okay.
I even tell them, I'm like, I don't really want to go over 20 hours a week.
Yeah.
I'd like to stay in like the 15-hour range.
Gotcha.
Just be really
Which is great.
part-time.
Sounds like that fits really well, because that's what you were alluding to earlier, is trying to have a little bit better balance with being good
It's
at
really
all
nice
aspects
for
of
my
life.
family side, yeah.
Yeah.
What about, so let's touch on pay, if you would, for a moment. You don't have to give us definitive numbers, but I want to know, in those 3 different settings you just mentioned with your career path, what did the pay structure look like in each of those settings?
So thoracic, clearly you're going to make more. You are doing more severe, like, I don't know, I'd just say in general, salary-wise, especially I was doing my salary on top of it, I'd get call pay. So they make really good money. And to come right out of school into that job, it was nice because I could pay off my student loans. Yeah. Back then, I think I started around like 120. And call pay, you would get like a set pay for every hour you're on call. And then if you get called in, it's time and a half, which is really nice. So on weekends, it's like, sweet, call me in. And some of my favorite cases were at 3 a.m. because they were the most exciting ones. And so it was like, this is great. I can make good money and be able to do this really fun surgery. But then the hospitalist is more like set pay. It's like shift pay, which is a totally different experience because it's like, this is your shift. You'll get paid this amount to work this shift. And whether you're there 5 hours or you're there 14 hours, you get paid the same amount. They consistently say it's like 10 hours, but you never know.
Right.
So yeah, it's shift-based pay. And then with this that I've been in, we've kind of bounced around. At first I started hourly because our hours were so inconsistent, but they've moved more towards having set pay for the 3 days, a little bit of set pay, and then anything over that is still hourly.
Oh, that's nice.
So
yeah,
it's
and
kind of,
you feel like it's competitive then?
I think so. Like, I don't feel like I'm getting ripped off or anything. Like,
that's the main question.
I feel like, I don't know, when you're working a job and I also want to be at home with my kids, I have to make it worthwhile to be in that job.
Makes
and
sense.
So I feel like I have to really be appreciative of the pay I'm making, because babysitting's so expensive nowadays that if it wasn't worth my time to be working, I wouldn't work. So yeah, I feel like they are competitive. It is not a bigger organization. That's one thing I think, understanding as an APP, working for a group like Intermountain, you're going to have usually higher and better benefits and more consistent pay. When you get into like smaller companies and smaller businesses, it varies a lot more and it's probably less consistent on where you should be. I know they try to look at like averages across states and professions, but even then, even within my own, they might say, oh, you're primary care, so you should be making this amount, but I'm actually doing surgery, so then it's also a different.
You're a unicorn.
I'm a unicorn. So how do you pay me? I don't know. So we've been playing with the idea.
You brought up a good point, because the big organizations have the benefits generally better than an independent practice or a slow growing practice. But the ceiling, I think, is a little bit higher when you work for a smaller group, especially if you start with them and you grow with them. I think there's maybe a little bit more opportunity to see growth in that light than the big machines that are going to cap you off eventually, just because they're standardizing it across. It doesn't matter if you are the unicorn. It's like they're going to put you into a space and decide from there how much you're going to get paid. So I kind of like, I think that's good for, like you said, APPs to know when they're going into it, deciding if they're going to work for a big organization or an independent practice, kind of those types of thought processes.
Well, and a huge obstacle we've run into on like the reimbursement side as well as like like getting the approval is insurance, because I can say, oh, I want to make tons of money, like you need to be paying me this, but the reality is what is the insurance company actually reimbursing for what I'm doing? And in our specialty, it's not great. The reimbursement's not great, but they need an assist, and so our group has to look at the cost benefit of having a surgeon assist versus an APP assisting, and how that plays out and allows the surgeon to be seeing more patients. And so they've done a lot of like analysis that way too, because really like sometimes reimbursement isn't great for what you're doing.
The cases that you guys are doing, are they typically reimbursing for an assist? Because I know in our world, it's a little bit hit and miss. There are simpler, I guess, less complex, shorter cases that insurance may not actually reimburse for any assist.
Right.
Other cases are longer, instrumented, more invasive, and they do compensate for having an assist.
Yeah.
What have you seen in your space?
Yeah, it's the same thing. Like some they don't reimburse for, some they do. But even like hysterectomies, it's the reimbursement for it for the surgeon and the team doing it is not as good as the reimbursement for the hospital. So we actually don't make very much money doing surgery in the OBGYN setting. Like they'll make a lot more money doing deliveries than they will in surgery. So, but also like surgery is such a necessity. It's a primary care. Like the things we're doing are needed. So it's kind of this balance that they have to play.
Well, and it's an efficiency thing, right?
Health.
Like when you have an assist that knows what they're doing, if your surgery is more efficient as a result of that, or the surgeon's feeling less burnt out because they have an assist, they have someone there, I think the payout's different in that regard.
Yeah, if you're getting 6 or 7 cases done efficiently where you maybe would have only been able to do 3 cases on your own, then I'm sure that gets
and I feel privileged that way because I have 7 surgeons I'm working with. So I actually do a lot more surgery than probably even surgeons in Utah, because
You're doing all of them.
I'm doing all of it for our group. So I get a lot of exposure. I have a lot of experience at this point. So I feel like I am confident at this point. They say coming out of school, like working a job for 2 years until you're really confident. Yeah. And I feel like I'm in a good place now where I can go into a tough surgery and be optimistic and not scared. Like I can feel good that I know what I'm doing. Yeah. So I think that's really important when you have an assist, and whether you're like working with them or you are the assist, to get to a place where you're confident in what you're doing and you can help, you like work together as a team in the surgery.
What's your primary role as the assist? What are the main functions that you're performing during a case?
Yeah, so like a hysterectomy, it depends what surgeon I'm working with because they all approach it differently. So a lot of times I'm the one placing the manipulator, and then I'll come up top, and while I'm placing the manipulator, they're placing ports and getting things set up. So we do, with just a hysterectomy, there's so many different ways to do it. You can do like an open abdominal hysterectomy, you can do vaginal. We did 3 vaginals yesterday. You can do it robotic, or what we call straight stick, which is just a laparoscopic way of doing it. And so every surgeon does it differently, and even some surgeons can do all of them, and just depends on the patient. So when you go in that day, it's just dependent on what they are doing for that patient.
Gotcha.
So are you retracting a lot, or are you having to like hold things out of the way? And
when it comes to just a straight stick, I actually hold, like they do their side, I do my side. So I'm doing what they're doing. But the biggest, I think, one of the toughest parts of it is usually closing the cuff, and the surgeon does that, and I just assist on that part.
Like you're tying, or
they're the ones like placing, yes,
and
exactly, and then I'll like pull the tissue up, or I'll pull the needle, or assist in that way. But they're the ones actually throwing the needle on that part. Yeah. So I know, but I feel like I'm right there working with them for most of it.
Very cool.
Yeah.
How about in that space in the operating room, what are some trendy things? We always like to know what's up and coming, what's new and different. Every specialty kind of has their things that they're innovative and updating guidelines and regulations or new procedures and techniques. How about in your world, what's trendy?
Yeah, I had a feeling you'd ask me this question, and I was like, it's hard because, birth control is always trendy. And hysterectomies are always in. Like since they started, I think they always will be. I don't think they're going anywhere anytime soon. I think hysterectomies are actually like the #1 surgery in America.
Oh, wow.
Is that right? We
you
should
tell me.
Google it.
Yeah.
I heard that statistic once, that it's the number one surgery in America, and I wouldn't be surprised. Because
do a lot of them, huh?
We do a lot. So those are always trending, but I feel like a newer one I've seen, we've probably done more in the last year than we have a couple years prior to that, would be labiaplasties. I don't know how much you want to know. This is where I like.
That's a cosmetic thing?
Yeah, it's
Purely cosmetic?
Well, not purely.
Is there a functional role in that?
Yeah, actually, we get a lot of people where their labia are just massive. Like, I don't know. One person explained it like elephant ears. And in that way, they can pull funny. I know you guys are men in this room, and
yes. So, yeah, we're done.
I love women's health, so I can keep going as detailed as you want.
Yeah,
but yeah, it actually can cause, like, some girls say they can't ride a bike, or they can't play. They'll play soccer and they're athletes, and they can't participate in their different like athletic events because it's causing issues.
What about infection? Does it increase the risk of an infection?
I wouldn't. That's probably a better question for the surgeon, but because I'm not in the clinic, so I don't see the post-op side or the pre-op side as often. But I think it's more just an uncomfortable. I know to have like insurance approve getting the surgery done, there has to be like more than just cosmetic reasons for getting it done.
Right.
But I think most of it is just the uncomfortable. Like some women's anatomy is just so different. And I think I personally went into medicine because I love the body, and I think that all the differences are beautiful, and I absolutely think the human body is amazing. But there's certain situations when it's causing you to not be able to live life and do your activities of daily living, when it's like impeding that, I think there's purpose for doing surgery and making your life better.
That's the key point that I have in most of my clinic visits. Totally different specialty, but quality of life is the term that comes into play. Should I do surgery or not? They ask me, what would you do? What should I do in this scenario? And ultimately, I can't put myself in your shoes. I don't know what your limitations are like. I don't know how accepting you are of your limitations. And really, how is your quality of life?
Yeah. And what are you doing? Because some people are like, oh, it's fine, it doesn't bother me at all. But then someone else is like, I ride a bike every single day for this. And it's hurting and painful. And so I think it really depends on, with the quality of life, like what does your life look like? It's so unique to that person. Yeah.
I think that's a good point. That's a good takeaway to remember.
Love that.
Yeah.
Yeah. Well, anything else we need to cover?
Story time.
Oh, boy.
Absolutely. Do you have a story you're willing to share with us? It could be emotional. I'm not opposed to shedding some tears on camera here. It could be funny. Always appreciative of a funny story, but something that's happened, experience you've had while being in medicine that you could share with us.
I don't know. What do you want? Do you want emotional or funny or?
I want funny.
Give us your best.
Do you want my worst day in the OR? No.
Not that one.
Don't scare everybody off now. Yeah, let them get their feet wet, and then they'll.
Yeah. I don't know. I funny. Well, I thought it was funny. Probably not to everyone else, but I loved the guy that came in. It was one of my 3 a.m. on-call nights. He came in because he was doing parkour over light bulbs and got glass all over in his chest cavity. And I don't know about you, but glass is really difficult to find inside the body because it's clear, and like shreds of it, when it gets bloody, it's just really hard to see. And so we were just picking through this guy's chest cavity all night. I found it amusing and I actually enjoyed it, but I don't think everyone else did.
Oh my gosh.
And anyway, that one was funny. I loved when I get huge pregnant, which also is funny to me that I work for my OB.
By the way, congratulations.
Yes,
you are
thank
expecting.
you.
So shout out.
I know. So I will be huge here any minute. But
we'll try and wrap it up quick.
Yes. My OB, the first baby, was like, well, you probably should try not to put on so much weight. And then by my third and fourth, they're like, we know you'll be fine. Like, you're going to get huge. It's fine. But I really do. My first baby, I went into this patient's room after doing this huge, I think he had lung cancer. So we took out a whole lobectomy for lung cancer. And he was this guy that was probably like 460 pounds. And it was not the easiest surgery. body size makes a big difference on how you
Definitely.
perform a surgery.
Yeah.
And so, and especially if you're the one retracting. And I had been just retracting for hours and exhausted and pregnant. And I walked into his room afterwards to go say hi and see how he was doing. And as I walk in, he looks at me and he goes, "Oh my gosh, you are huge." And I was like, "Oh,
Same to you.
No, I didn't say that, but in my head, I was like, be nice. Like,
Yeah.
I was like, I am huge. Okay. It was just so funny. I just laughed. Like, some of their comments are so funny right after surgery.
I love that.
Oh, my favorite right now with surgery is the patients. We've had quite a few that right as they're falling asleep, they're like, "Make sure you tell the doctor." And then they fall asleep. And you're like, "What?
Cliffhanger.
What are we going to tell the doctor?"
And they won't remember when they wake up.
Oh,
Hey, what
no.
were you going to
Finish
say
that
when you went to
sentence.
Oh yeah, they have no idea. But everyone in the room's like, "Wait, what? Oh, dang it!"
I love that.
Yeah,
I love that.
yeah.
Well, that's been great. I guess we'll wrap it up. That's been a lot of fun. We appreciate you being here. Tyler, what'd you learn today?
I was just about to ask you the same
No way.
thing.
Nope.
Oh, okay.
Nothing?
No, I learned a ton actually. And I think it was so good to hear your story. And I think the takeaway is that you can be a unicorn. You can find a way though.
Yeah.
And being an advanced practitioner, there are so many aspects of medicine you can find yourself in, and you found a spot where you're passionate about, and it also works with your home life. And I
Yes.
think the biggest takeaway I got from that is just, find your niche. Don't be afraid to prod around and find where you fit. And it sounds like you're making a great impact there, and they're grateful to have you, because we can appreciate that from being on the neurosurgery side of things. Having an assistant in the OR is huge. We hope it is anyway.
Yeah.
And, that's how we'll retain our jobs. So, no, I really appreciate you coming on today, sharing your story with us, spending time with us.
Yeah.
And it was good to catch up with you.
I appreciate you having me. It's
Yeah,
fun.
this has been fun. I definitely learned a lot. It was great. How would people connect with you? If somebody had follow-up questions or other comments, or wanted to get to know a little bit more about what you're doing, how would somebody be able to reach out and connect with you?
Yeah, we were talking about this because I'm in such a niche. I feel like most of my patients probably don't even know who I am or that I'm even there, because they're asleep the whole time. So if you want to reach out to me, I think personal questions, feel free on social media. I have an Instagram and Facebook. I'm not great at social media, so don't feel bad if I don't get right back to you. If you have more general questions about women's health, please reach out to Valley Women's Health. It's an excellent place to go to for any resources, or if you need to see a doctor or a nurse practitioner or a PA, midwife, any of them. They have all of them there. So
I'll validate for you too. We don't work for the company, so we don't have any vested interest, but I know the reputation, and the reputation is excellent with
Absolutely.
the clinic.
Yeah.
Great providers, great office. So
yes.
I would echo that. Valley Women's Health has been a great supporter of the community.
Yeah.
With our office, Summit Brain and Spine, we can be reached through our Instagram as well, Summit Brain, Spine, and Orthopedics. Our YouTube channel is Summit Medical Institute. And as always, come see us in person Tuesday mornings, 7 a.m. for our interdisciplinary case discussions at the Mountain Point Hospital in Lehigh, Utah. Special shout out to our production team. We appreciate all that they do for us. Sarah Mendenhall, thanks for joining us. This has been excellent.
Yeah. Thank you.
And we'll wrap it up. This has been another episode of the Many Minds podcast, the Many Minds for Better Outcomes, encouraging collaborative community care. We'll see you next time.
Stay tuned.